Good afternoon and welcome. Thank you for attending this presentation today. Firstly, I would like to begin with acknowledging the traditional custodians of the land on which we live, work, and study, and recognize the continuing connection to land, water, and community. I pay respect to elders past, present, and emerging. Today's presentation will look at how to demonstrate culturally competent and safe nursing care for our Aboriginal and Torres Strait Islander communities living in the urban areas of our country. Firstly, we will look at the general backgrounds of these communities and then identify the social factors that contribute to their access to healthcare. We will then look at the statistics relevant to our selected health issue of cardiovascular disease and the health behaviors and risk factors associated with them. We will look at lifestyle factors and how to improve health literacy to enable choices that lead to improved health outcomes. Firstly, I would like to give you a brief introduction to the general background of Aboriginal society, specifically about those Aboriginals living in urban areas. I will show you some research and statistics that cover the demographics and some social determinants of issues that will benefit from health promotion. According to the Bureau of Australia, the population of Aboriginal people has still been growing continually over recent decades, as indicated on the graph on the right-hand side. It can be seen that there are more than 54% of Aboriginal and Torres Strait Islander people that now reside in the major cities of Australia, for example in Sydney. It also shows there are more women than men, and there are more of the younger generations moving to city as opposed to remote areas. Moreover, Aboriginal society has a fairly high birth rates as well as a higher death rates within their population when compared with the general population. Generally speaking, health outcomes in Aboriginal society are still at a comparatively poor level in relation to the general population, and therefore, as indicated within my part of this presentation, I have determined that a few factors stand out as being the major reasons leading to these poor results, which I will discuss in more details in my next slides. The important points that I have observed and which I truly believe will affect the outcomes of any utilized health promotion strategy, including education level, economic status, health literacy, and also current health status observed in Aboriginal people. Now we will start with the first point, which is the education level. Again, from the figures on the bureaus of statistics websites, I found that in 2008, the school retention rates for Aboriginal and Torres Strait Islander was only 47.2%. This is less than half of their children that are completing their school education. A lot of the students leave school before they finish grade 5, and this causes poor understanding of health, which perpetuates into adulthood, results in lack of insights into the importance of practicing a healthy lifestyle and having appropriate medical treatments when it is necessary. Therefore, this results in Aboriginal people usually have poorer health condition than non-Indigenous people. Also, from the studies as shown in the graph at the bottom of this page, which describes the traditional medical treatments which are commonly used in Aboriginal society, such as healing songs and herbal medicine, which are non-congruent with modern medical practice. Thus, I strongly believe that the improvements in their medical understanding and knowledge will be achieved through appropriate health promotion strategies, which will lead to improved health outcomes in Aboriginal society. Then the second major reasons are economic status and income level. Based on my research, it shows that even in recent years, although the situation has been improved a lot, especially for those who live in urban area, most of the Aboriginal people are still living in relatively poverty. In 2011 census, Aboriginal people reported 56% Aboriginal and Torres Strait Island people having an average monthly income of $200 to $799, while the non-Indigenous people have an average of $400 to $1,249, which is almost double the figure. And also, the unemployment rate of Aboriginal people is still higher than non-Indigenous people. The unemployment rate in 2014 to 15 shows that Aboriginal people still remains nearly 3 times more likely to be unemployed than non-Aboriginal people. Additionally, 36% lower rates than non-Indigenous of home ownership is also another indicator. Concerned with the high living cost in major Australian cities, it makes sense that they wouldn't be spending money they do not have on opting proper medical treatments despite suffering from ill health. From the other research, which is conducted by People Waterfalls, has also determined that Indigenous people participate in health risk behavior more often than non-Indigenous people, and this is definitely indicated in poor health outcomes and also includes heavy daily smoker, alcoholism, inactivity, and obesity. In the slides, I have done a screenshots for these risk factors for urban Aboriginal peoples. The figure enhances our understanding of the current status of unhealthy lifestyle in Aboriginal society. Heavy daily smoker 14.1%, nearly double the figure compared with non-Aboriginal population, and also higher rates for alcoholic population. And we can find that the most serious one among all of them is obesity. And this is also the reason why we choose to study on how to improve health promotion on cardiovascular disease for Aboriginal people in this assignment. And the other study has also been proven by the table in the VOA in 2014. The first two highest rates disease for Aboriginal and Torres Strait Islands is heart disease and diabetes. Knowing what is the most serious disease affecting with the Aboriginal population, my next curious question is what available health services are currently being provided to Aboriginal society by the Australian government, especially for dealing with cardiovascular disease. According to the Draft National Framework for Health Services for Aboriginal and Torres Strait Islander children and families, there are a few cultural competent care are now available to including family-central care, relationship-based care, trauma-informed approaches. It now provides specialist weekly services including diabetes educators and pediatricians for children's health care and education. Moreover, it also supports with various health programs such as one-stop diabetes shops and Web Baby program. But I still have a big concern. According to BOA, the data about health of Aboriginals who lives in urban areas are never completed. Even for those existing one usually is not up to date. This might cause by people changes the location frequently between urban area and remote area, and others might not even create a medical records in any proper medical facilities. From my point of view, this will cause the issues for disease analysis and also become an obstacle for centralized health management for Aboriginal populations in Australia. Now I will go into talking about some clinical impacts of cardiovascular disease on Aboriginals. I would like to start with the two questions. Firstly, what is cardiovascular disease? It is a condition in which heart and blood vessels do not work properly and blood does not flow at a normal rate. Cardiovascular disease is one of the leading causes of death in Indigenous people, but it is worst in Aboriginal and Torres Strait Island people living in urban areas in different parts of Australia. My second question is, what are social determinants of health? According to Australian Bureau of Statistics, the social determinants of health can be defined as the conditions or environments in which people are born, work, grow, and live. From this definition, it can be concluded that in human society, healthy and unhealthy conditions and resources are not randomly distributed. The extent of cardiovascular disease on Aboriginal and Torres Islander people, according to Canadian Journal of Cardiology, 1 in 4 people in Aboriginal community living in urban areas are suffering from cardiovascular disease, and over 90% are at least one risk factor of cardiovascular disease. In 2015, 40% of total deaths amongst Aboriginal and Torres Strait Islander peoples were caused by cardiovascular disease. Aboriginal and Torres Strait Island people were 70% more likely to die from the circulatory disease as compared to non-Indigenous people. Therefore, Aboriginal and Torres Strait Island people were 20% more likely to have cardiovascular conditions. Why are Aboriginal and Torres Strait Island people more often affected by heart and circulatory conditions? Evidence from various research show that Aboriginal and Torres Strait Islander people have higher rates of having cardiac and heart disease, as well as poor access to health services. Smoking rates for Indigenous Australians were significantly higher when compared to different age groups of Aboriginal and Torres Island people. Indigenous Australians are more often affected by cardiovascular disease because the majority of Australian Aboriginals aged 21 years and over did not meet the daily recommended balanced diet, which includes an adequate intake of vegetables and fruit. More often, there are different aspects that contribute to poor health of Indigenous people, which include clinical and lifestyle risk factors, which will be discussed in the next slide. Here we are going to discuss different clinical risk factors which affect cardiovascular conditions. Major modifiable clinical risk factors include diabetes, high blood pressure, stroke, rheumatic heart disease, and coronary heart disease. First one is blood pressure. 22% of Australian Indigenous adults have high blood pressure, and more than 70% do not even know what are they suffering from hypertension. It is one of the major risk factors that leads to stroke, heart disease, and kidney disease. The second clinical risk factor is diabetes, with 13% of adult Indigenous people having diabetes, 3 times more than the rates of non-Indigenous Australians. Those who are diagnosed with diabetes, which is 60%, had high blood sugar level, indicating that they have poor health condition, while 14% did not even know they have diabetes. Rheumatic heart disease is another health concern. Many are hospitalized for acute rheumatic fever at 7 times the rates of the non-Indigenous population. In Australia, rheumatic fever is still common in many Indigenous and Aboriginal communities. In between 2005 to 2010, all cases recorded for rheumatic fever were of Torres Strait Island people and Aboriginal communities. Indigenous people are 69 times more likely to develop rheumatic fever as compared to non-Aboriginal people. Rheumatic fever can be commonly seen in young adults and adolescents in Aboriginal Torres Strait Islander people, which is 8 times more than the other Australians. Aboriginal and Indigenous communities, especially in urban areas, suffer stroke due to different risk factors in younger age group. Indigenous adults as well as are likely to be hospitalized twice due to stroke on hypertension twice, and 1.6 times as likely to die from stroke as compared to non-Indigenous Australians. Indigenous people in Australia are 11.5 times more likely to die from coronary heart conditions and disease as compared to non-Indigenous people. Coronary heart disease leads to heart attack and stroke, which is life-threatening in many cases, and to different risk factors in younger age. Indigenous adults as well are likely to be hospitalized twice due to stroke on or hypertension twice, and 1.6 times as likely to die from stroke as compared to non-Indigenous Australian. In this slide, we are going to highlight some modifiable lifestyle risks which are in the following list. Smoking. 45% of the Australian Aborigines aged 80 years and over are 3 times more likely to smoke than the non-Indigenous in Australia. Among Indigenous and Aboriginal Australians, smoking caused about two-thirds of cardiovascular disease and lung cancers. This led to a death rate of 2 out of 5. Overweight or obesity. 67% of Torres Islander and Indigenous Australians aged 60 years and over are obese or overweight. Increasing rate of being overweight in adults is leading to cardiovascular disease in present years. Alcohol consumptions. 26% of Indigenous and Aboriginals in urban cities of Australia aged 17 years and over abstained from alcohol in the previous 11 months. After adjusting for various age structure of population, this was 1.7 times the non-Indigenous Australian rate. In year 2012 to 2015, 56% of Australian Aboriginals exceeded the binge drinking at least twice in the last 15 months. To different risk factors in younger age, Indigenous adults as well are likely to be hospitalized twice due to stroke and hypertension twice, and 1.6 times as likely to die from stroke as compared non-Indigenous Australian. According to the WHO, health promotion is improving people's health through increased to control their health determination. I want to discuss how to improve Aboriginal health by 5 main points, which is building public policy, creating supportive environment for health, strengthening community action for health, developing personal skills, and reorienting health services. Let's start with the first point, building public policy. At first, since 2006, Australians pick Aboriginal and Torres Strait Islander and non-Indigenous health bodies, health professional bodies, and human rights organizations published the Close the Gap campaign. According to the Heart Condition Twice, as common in Indigenous Australians, the campaign's goal is to develop the health and life expectancy of Australian Aboriginal and Torres Strait Islanders. The statistics shows that Aboriginal and Torres Strait Islander people, compared with the other Australians, are as following. They are 1.2 times as likely to have cardiovascular disease, 1.4 times more likely to die out of hospital from coronary heart disease, 3 times more likely to have a major coronary event such as the heart attacks, to 3 times as most likely to be hospitalized for coronary heart disease and heart failure, more than 2 times as likely to die in hospital from coronary heart disease, and 6.7 times as likely to be hospitalized with acute rheumatic fever and rheumatic heart disease, with rates varying with age groups. So, government has published policies to improve Aboriginal health. Mr. Dixon said, "We are committed to improving Aboriginal and Torres Strait Islander health and reducing the gap between Aboriginal people in cardiovascular disease, mortality, and morbidity." My second point is creating supportive environments for health. Moving to my next point, nurses can be creating supportive for health. The last one method of environment patient-centered care is applying for social work services. This is because it might cost the patients a lot of money to treat cardiovascular disease in the hospital. However, the patient is homeless and may have no stable jobs, so the patient may have economic difficulty for the treatment in Australian urban area. There are a lot of social work services which is departments of Australian government. The social work services provides various assistance and care for people who have difficulty in life, such as homelessness. Nurses could help the patients to contact a social worker to follow the patient's situation and apply for both economic support and mental health help. My third point is strengthening the community actions for health. In 2003, New South Wales Health and the Aboriginal Health and Medical Research Council of New South Wales cooperated and established a collaborative Centre for Aboriginal Health Promotion in Redfern, Sydney. This centre is located in the urban area of Sydney and provides effective and professional help for urban Indigenous health promotion in New South Wales. There are mission of the center. For example, the center collects and analyzes information, innovates various approaches for helping Aboriginal people who get cardiovascular disease and preventing healthy people from cardiovascular disease. They provide effective methods for Indigenous people to quit smoking, make healthy dietary interventions for them, such as a low-fat, low-sugar, high-fiber diet. Typically, the effectiveness of health promotion is the key priority in the New South Wales Aboriginal community. Point is developing personal skills. Literacy, we are going to talking about developing personal skills from two aspects, which are affective and cognitive skills, which rely on changing daily lifestyles and environment factors to improve personal and social health. The living skills helps people get the efficient way to improve their living condition and promote their health. According to the Public Health Wales Observatory's 2011, of people exercised fewer than 5 days during the previous week. Around 43% of adults reported drinking above the guidelines on at least 1 day in the past week. Doing physical exercise fewer than 5 days per week. Eating fewer than 5 fruits and vegetables per day. Drinking above guidelines at least 1 day per week, and high blood pressure are all the risk factors for cardiovascular disease. People are encouraged to using these skills to change their living and dietary habits, such as being physically active, recognizing health food options, eating more fruits, vegetables, and less junk food, decreasing the amounts of tobacco and alcohol to promote their health and decline of the rates getting cardiovascular disease. Reorienting health service. Reorienting health service not only focusing on pursuit of health, but also pay attention to the total needs of Aboriginal people. By the way, according to PDHPE, cardiovascular disease causes the largest morbidity and mortality rates in Australia, especially in urban areas. Reorientation health services, such as providing medical services and health promotion devices for Aboriginal people who have cardiovascular disease, which includes providing free blood pressure checks, giving intervention for health, offer regular check for health pregnancy. However, according to the figure 2, in 2012 and 2013, due to different reasons, some Indigenous Australians not access healthy services when they needed to. One of the important reasons is cultural appropriateness of services, which means the Indigenous people did not receive cultural respect when they accessed health services. Thus, Aboriginal and Torres Strait Island health workers plays an important role in providing cultural competent health services for Indigenous people. For example, in the cardiology department of a WA hospital, these Aboriginal health workers could provide cultural security and increase participation in cardiovascular rehabilitation. Therefore, reorientation health services could aim a temporarily Aboriginal and Torres Strait Islands to provide culturally health services. To conclude today, I would like to emphasize the reasons for doing this presentation is to demonstrate how cultural competent and safe nursing care for our Aboriginal and Torres Strait Islander communities can be achieved. We identified the clinical risk factors for cardiovascular disease in our selected community and looked at the reasons why they are overrepresented in these statistics, at a rate 70% greater likelihood of dying from heart disease. We identified the 5 main contributing lifestyle factors that needs to be tackled, and the 5 main actions that needed to be focusing on to bring change about. Finally, I would like to state that increasing the health literacy and focusing on daily healthy living choices is key to changing our community of focus, and this is achievable with accessible and culturally competent and safe delivery range of nursing care available within our targeted communities. Many thanks for your attention today.